Good afternoon, everyone. My name is Eric McDonald. I'm the County of San Diego Health and Human Services Agency Chief Medical Officer. We are here today to discuss COVID-19 medical and health misinformation. I'm very pleased to be joined today by two local medical experts for this discussion. They are Dr. Mark Sawyer, a board-certified pediatric infectious disease physician at Rady Children's Hospital San Diego, who is also the residency director for pediatrics at UC San Diego. He's on the Food and Drug Administration's Vaccines and Related Biological Products Advisory Committee, which reviews the COVID-19 vaccines, among others, and on the state of California's COVID-19 Scientific Safety Review Work Group. He's also the medical director of the UC San Diego Immunization Partnership and an associate editor for the 2021 American Academy of Pediatrics Red Book, the Bible of Infectious Disease for Pediatrics. Also joining us is Dr. Jess Mandel, who serves as the Kenneth M. Mosher Professor of Medicine and the Chief of the Division of Pulmonary, Critical Care, and Sleep Medicine at UC San Diego, as well as Vice Chair of UCSD's Department of Medicine. A physician frontline provider in the intensive care unit during the COVID-19 pandemic, Dr. Mandel also oversees critical care surge planning for UCSD Health. In addition, he developed and led efforts to assist Tijuana and Mexicali's medical communities in dealing with their surges of COVID-19 patients. And as an aside, on behalf of all of us in this binational community, I would like to thank you and all of those who work with you to support our colleagues in Baja California. Our focus today is the Tuesday, February 8th COVID-19 update presented to the San Diego County Board of Supervisors. And while the discussion yesterday was broad, we will focus exclusively, as requested by the board, on misinformation related to medical and health issues. As I've mentioned in prior panel discussions, the county has established a link on our longstanding COVID-19 website, coronavirus-sd.com, that is meant to assist the public in evaluating misinformation and information on COVID. If you go to our website, you'll see a banner marked Evaluating COVID-19 Information. And by clicking there, you can learn more about the different types of incorrect information. There are links on the website to credible sources, some false claims that have been paired with facts, as well as some frequently asked questions. When we're done here this afternoon, this session will be posted on the website. Today's session is simultaneously translated into Spanish, and you can access that by clicking on the translate button on the bottom of the screen. And one last introductory comment, both of our panelists today work for UCSD, but neither have any income or any fiduciary relationship with any pharmaceutical company. As your moderator, I have never had a relationship with a pharmaceutical company and receive no money from them. So with that introduction, I'd like to start with Dr. Sawyer. There were a number of comments at yesterday's board meeting that have been made at prior board meetings about vaccine effectiveness and concerns about safety. And you actually gave a very nice presentation in a previous panel about how the vaccine works and the processes that are in place in this country to monitor vaccine safety. I think that the local data shown at yesterday's meeting is actually excellent real-world evidence of effectiveness, where there are lower case rates for individual infections and hospitalizations and deaths amongst those that are fully vaccinated and boosted, especially compared to those who are unvaccinated, and that there's national, state, and international data that actually backs that up. But I'm wondering if you might be able to say, are there any new concerns about safety or effectiveness that you're aware of regarding the current vaccines, and any comments you want to make about pediatric patients, knowing that the eligibility may be expanded in the near future to younger patients?
Sure, that's a lot of territory to cover, but let me start with the safety issue. The wonderful thing about our current era of communication and collaboration is we can accumulate data from around the world very quickly on, in this case, any new emerging vaccine side effects or concerns about the vaccines. And I was surprised recently to hear that we have actually given billions, with a B, billions of doses of COVID vaccines around the world, several 100 million in the United States, at least 10 million to children between 5 and 11 years of age since we started that in November. And because we have structures in place to monitor reactions to vaccines, we have accumulated that much experience with these vaccines. And what I can say from that is there are no new concerns. We do know there are side effects from these vaccines. Everyone acknowledges that. They range from very minor side effects like sore arms and redness at the injection site, all the way up to serious reactions like allergic anaphylaxis type reactions. People, I'm sure, have heard about myocarditis as a recognized side effect of the mRNA vaccine. There are some clotting disorders that occur with the Johnson & Johnson type product of vaccines. And these have been clear to us for at least a year now, and no new side effects have emerged despite continuing to immunize millions of people. In fact, we know more about these vaccines than any other vaccine in history that's been rolled out. So I can say with complete confidence what the side effects are. And I can say that for all age groups, including children, the risk from a side effect from the vaccine is lower than the risk from getting COVID and the various things that can happen after COVID. And you asked me to comment on children. People certainly are aware that in general, children are less severely affected from COVID. That is thankfully true. But that doesn't mean they're not occasionally seriously affected. So we have had close to 100 children hospitalized at Rady Children's in the last month during the Omicron surge. Some of them have been in the intensive care unit. Some of them have gotten the MISC inflammatory reaction that happens after COVID in children. And we're waiting to see how many of them get long COVID, the protracted symptoms that both adult and children get. So people need to remember that when they're thinking about the risk and the benefit of the vaccine. There is risk from getting COVID, and there is a small, tiny risk from getting the vaccine. But when you compare the two, you end up on the side of getting vaccinated. And I think that is likely to extend to the very youngest age group now coming up next week, 6 months to 4 years of age, which is being reviewed by FDA and the CDC next week. So there'll be more information coming forward on that age group.
Thanks, Dr. Sawyer. You actually anticipated my next question, because people have commented that the death rates are far lower in younger populations, but there are obviously other significant outcomes that need to be taken into account when talking about the risks versus the benefits of getting vaccinated. And you mentioned a couple of them. I wonder if there are any other new things that are emerging in terms of recognized lasting effects in terms of children. I know anecdotally I've heard from some of my emergency medicine colleagues that some upper respiratory illnesses and croup-like illnesses have been noticed more recently with Omicron, and I've also heard about perhaps a link with diabetes. I wonder if you have any comments on that.
Yeah, both of those things have come out in recent months. Omicron as a variant of the SARS-CoV-2 virus seems to affect the upper respiratory tract more, and thankfully less of the lower respiratory tract that Dr. Mandel will talk to us about in adults who get very severely ill. And that sometimes manifests as croup, that barky cough that young children get with a number of different viruses. So yes, we're seeing that. And there was the recent link between either acceleration of the presentation of diabetes or perhaps an even more direct link, but from getting COVID itself. So there are risks. And although people sort of hang their hat on the statement that the death rates in children are much lower than they are in adults. That is true, but there are deaths from COVID in children, and I would argue that no death is acceptable when we have a way to prevent it, which is the vaccines, which although they don't work as well for Omicron as they did for earlier strains, they do still work at keeping you from getting sick enough to end up in Dr. Mendel's ICU and or dying from COVID.
You know, there was also a specific concern raised yesterday that pediatricians are, quote, mixing vaccines, or that there were risks perhaps of getting the COVID vaccine along with other routine childhood immunizations. I wonder if you could address that and really talk about why it's important that children are up to date with all of their recommended vaccines.
Yeah, that's an important issue that we face all the time in pediatrics. We do give a lot of vaccines, particularly at the young child routine visits at 2 months, 4 months, 6 months. And so we're very used to giving vaccines simultaneously. It is a very good question to make. We need to make sure that it's safe to give the COVID vaccines along with other vaccines. But again, as I mentioned, we've given now 10 million doses of COVID vaccines to kids between 5 and 11, many of those in conjunction with other vaccines. And we're not seeing any new or different or unusual side effects. If by mixing, people are thinking that the vaccines are being combined in some way and given in a single syringe without being forthcoming about that, I can assure the community that that doesn't happen. Pediatricians have been trained since day one of their pediatric training that it's not appropriate to put two vaccines together in the same syringe, because if you do that, you cannot rely on their effectiveness or even their safety. But so I'm certain that that's not happening. And the fact that we're giving COVID vaccine at the same time as others is sort of inevitable, because we do need to make sure that kids are up to date with all their other routine vaccines. Otherwise, we're going to run the risk of outbreaks from good old-fashioned things like measles and chickenpox.
Thanks. Dr. Chip Schooley, one of your UCSD colleagues, gave a very nice presentation at yesterday's board meeting on how the immune system works, and actually gave some excellent evidence as to why booster shots are needed for the Omicron variant in particular, for people who have gone a number of months since their basic series. Do kids need boosters too?
Probably. The answer is yes. We're still accumulating that data. Remember, we started immunizing children later, so we haven't had as much time to see how the immunity may wear off somewhat over time, but the early indications are that it does. And I think if I have to predict, I think it is likely that children will need at least one booster. The whole booster question is still a little bit up in the air, since again, the vaccines, even without a booster, are pretty good at keeping you out of the hospital. With a booster, they're very good at keeping you out of the hospital. So I think we'll probably extend that approach to children as well.
Oops, I'm just trying to unmute myself. Thanks. Dr. Mandel, I'll turn to you here. You're a frontline hospital provider who's taken care of COVID cases really since the beginning of the pandemic. And I wonder if you have any comments about how things have changed in terms of hospitalized cases that you're seeing now that since the vaccine has become available versus the beginning of the pandemic.
Yeah, it really is very different since the introduction of the vaccine. And I think, for me, it's one thing to see the numbers, but when you actually see the patients every day and really see how large a proportion of these serious cases in the ICU are among unvaccinated patients, it's very sobering. You hate to see, people missing an opportunity to prevent a life-threatening illness and end up as sick as they are. So, many days when we walk around in the intensive care unit, it's, maybe 5% of patients are vaccinated, sometimes less, sometimes up to 10%, but always a small minority relative to the unvaccinated.
A couple of people made comments at the board meeting that people who are not vaccinated are not getting treated at the hospital, or actually getting different treatments compared to people who are vaccinated. And that's why they're having worse outcomes. I mean, I wonder if you could just, as the person who's there taking care of them, I wonder if you could talk about how people with COVID are actually getting treated and how things might be different in the case of people who are unvaccinated.
Yeah, and it's great to have a chance to address that, because the short and very, very definitive answer is that we treat every patient with maximal effort and compassion and do everything we can to make every patient better. And we make no distinctions about anything. We don't make a distinction in terms of how they're treated based on vaccinated or not. We don't make distinctions based on, whether they're on their income, whether they're a inmate, whether they're in the country, undocumented. If they're there, we're going to help them. And I get asked about this a lot, when I'm my neighbors and I'm walking around the neighborhood, doesn't it make you mad when people are not vaccinated and get sick? And the answer is no, we don't get mad at our patients. We try and help our patients. And, that this is not a distinction we make in medicine, because people make all sorts of judgments for their health that unfortunately are not always great. We don't withhold care from people who smoke. We don't withhold it from people who are overweight. We don't withhold it from, any number of things. We don't go down that road, and we shouldn't go down that road. We will make maximal effort for every patient that we can help, and do so in a compassionate, non-judgmental way.
Yeah, thanks for really reiterating that. We all on this call know that, and I sort of hate to have to say that, but I'm glad you did. So thank you for that. When you talk to the cases and you care for them in the hospital who are people who have not been vaccinated, what do they tell you about the reasons that they weren't vaccinated? That led them to or either delay or not be vaccinated at all?
Yeah, it's an excellent question. And, first of all, I think it's good to be skeptical in life. And it's important that things pass the smell test and make sense. And it's important to ask questions. And it's important to listen to the answers. And I think having someone like Dr. Sawyer here, who's really so close to the data and can speak in such a sophisticated manner about this, is fantastic. The main things that I tend to hear from patients who are unvaccinated, who are hesitant to get vaccinated, is first that they feel that this is new. This, as in distinction to other vaccines, hasn't been around as long, and they worry that something is being missed because it's new. And I think hearing Dr. Sawyer and others speak about how many millions of doses and how extensive the database is, and to speak very frankly and openly about the low potential for side effects and what those are, I think is something that people need to hear. Sometimes I hear people say that they think they may have had COVID already, and or they did have COVID already, and they don't need the vaccine on that basis. And I think it's pretty clear to us that a combination of vaccination and prior infection really provides much stronger immunity than just prior infection alone, and that there's things to be gained there as well. So I think those are the main types of things that I hear, but it's variable, and I think, as doctors, we really want to ask why. We really want to listen and really want to address those concerns and as directly as we can. And I think the data really are quite overwhelming on the benefits of vaccination, and certainly in ourselves and in our families, our actions. We put our money where our mouth is in terms of our faith in those vaccines.
If I could just add one more comment to this question of the newness of the vaccines and the concern we often hear that there might be long-term side effects from the vaccine. And there is no vaccine that we have ever used in this country that has a long-term side effect. So the side effects are always in the first few weeks. The only long-term thing that happens with vaccines is their protection may wear off, and that's why you need boosters. But there's no such thing as a vaccine that causes a problem years down the road.
Yeah, thanks for mentioning that, Dr. Sawyer, because there was somebody at the board meeting yesterday that raised the debunked issue about autism and vaccines. And again, that always seems to come up, but I think I'm so glad that you re-emphasized that. So thank you. There was another comment at the board meeting yesterday that many or most of the severe cases of COVID are people who are vitamin D deficient, and that vitamin D would be either an appropriate outpatient or inpatient therapy. And maybe I can direct this to Dr. Mandel. Is this something that you're seeing in the patients that you actually are caring for? And is, in your view, is there any role for vitamins in COVID treatment?
Right. I think it's important. Good nutrition is important for everyone, and making sure that our diets are reasonable and that we take care of ourselves and avoid these deficiency states. And I think that's important. When people have looked in terms of using vitamins for treatment for COVID or for other severe illnesses, unfortunately, the data are disappointing in that the trials have not tended to show an effect at that level. I think as a risk factor, having low vitamin D, there are some intriguing data that need to be explored more fully. And I think it certainly makes sense to follow the recommendations in terms of screening for vitamin D deficiency and addressing it if it's found. But at this point, it's not part of our treatment armamentarium. We'd love to add it as soon as there are data really showing that it works, but we're just not at that point now.
Thanks. I know that we've actually talked about that, and we've talked about this next one too, to give you a chance to reemphasize it since it came up yesterday. The role of ivermectin in treating or preventing COVID came up again. And again, is there anything new that indicates that ivermectin is useful in the treatment or prevention of COVID?
Yeah, at this point, no. At this point, it is not part of it. And a lot of the interest in ivermectin really came about from sort of test tube studies that suggested there might be a role in modulating the impact of COVID. And there's two issues to keep in mind. Number one, the concentrations of the drug that were used in the test tube are at such a high level that they can't be produced safely in the body to mimic that. But I think for those of us in the field, there's a lot of things that show some promise early on in test tube and in animal models, but where the rubber hits the road is really seeing if it works in humans. And so far, unfortunately, we have not found a role for ivermectin in the prevention or the treatment of COVID for humans. It doesn't mean it's not worthy of further study. And again, I think we're all rooting to find as many effective options as we can, but at this point, it's just not there. And I think we've learned in other diseases in the history of medicine over time that you need to look before you leap. That sometimes with the best of intentions, physicians have tried to employ unproven therapies and only find out later that it's made things worse rather than better. I think you're muted there, Eric.
It helps if I put myself not on mute. That's so. Thank you. Yeah, thanks for making that comment. And a couple of the other comments that were made yesterday were really addressed before. I think very specifically, people love going back to the VAERS database and then listing off categories of things that have been reported through the VAERS system, and then stating that those were caused by the vaccine. And I know, Dr. Sawyer, you've mentioned this a couple times in previous venues, but it's probably worth saying one more time that VAERS is an important surveillance system, and it is useful in the types of systems we have set up to be able to detect potential vaccine side effects. But just simply downloading information and then adding up the numbers is not an appropriate way of saying these are things that are caused by the vaccine. And there's a great warning on the website that says that, but people just seem to blow right by it, and they get mad at us for not addressing their concerns, that we're not addressing their concerns about VAERS, and we keep giving the same answer. So I don't know if there's any extra information you have to give about that, but or a different way of saying it that might get through.
Well, I'd like to direct people to a different acronym. So VAERS is the Vaccine Adverse Event Reporting System, VAERS. It is an important part of the safety network that's been built for all vaccines and has been used a lot for COVID. But the more important acronym is VSD, the Vaccine Safety Data Link. You can find information from that group also on the same CDC website as the information for VAERS. The Vaccine Safety Data Link is a network of large provider groups who can study something like 10 million people simultaneously through the electronic health records to look for side effects. So the way our system works is anybody can report something to VAERS. You can report as a patient or a parent of a child who you think maybe had a side effect from a vaccine. Doctors can report. The companies actually report to VAERS once somebody calls them and say, gee, I think I got a side effect from your vaccine. But just because one thing happens in a time frame after another thing doesn't mean that the first thing caused it. And that's what the difference is. VAERS simply says this thing happened after that thing. What the VSD does is looks at everybody who either did or didn't get a vaccine and determines did they get myocarditis? Did they get pneumonia? Did they get autism? Did they get diabetes? And they can compare the groups and scientifically address the question. So VAERS is for raising the question. VSD is for answering the question. So it's a great combination. It works well, but you cannot just lean on the VAERS data because it has lots of reports that are not associated. Just to punctuate that, I could get vaccinated today and get hit by a truck tomorrow. And I could report that to VAERS that I got hit by a truck after I got the vaccine. And somebody could say, aha, you got hit by that truck because you were vaccinated. And the VSD system would be able to prove whether that's true or not.
Yeah, thanks for that. One other surveillance tool that people either seem surprised at or not understand is actually wastewater surveillance. And that's been a very useful tool, especially in the last number of months, for us to identify variants that are in the local community even before clinical cases show up. And in fact, we locally here in San Diego and you at UCSD and the laboratories there have really shown that you can get a really good early warning of increased numbers of cases, or even the specific presence of an individual case down to a specific building on campus. And people seem surprised about that. And there were people that mocked that, frankly, at the Board of Supervisors meeting. But I have to say, it's been an extremely useful tool. The good news is that the burden in our wastewater has been going down and was starting to go down before the case numbers in San Diego were going down. So that's a glimmer of good news. But I will say that the amount of virus that we're still continuing to detect is at very high levels. And so we are, in fact, very grateful that the case counts are going down, but still with over 2,000 cases a day now, that's still substantial to a very high transmission in our community right now, and people should not really forget that. And also, I really just like to finish up by asking a couple of questions, or just one last question. Are there concerns or maybe aspects of misinformation that didn't come up yesterday that you're picking up from your patients or from your colleagues that you think might need to be addressed here in this venue? And I'll start with you, Dr. Sawyer.
Well, I think we've touched on one question that continues to circulate. I wouldn't call it misinformation. It's just an unknown, and that is the booster dose question. And do we need them, and how many might we need? I wish we could predict that right today, but we certainly learned through the Omicron surge that we do need it, at least up till this point in time. Other than that, I've already addressed the major issues that keep circulating around pediatric vaccination, the question of whether children really need the vaccine, whether they're severely affected by COVID, the disease, and whether there are side effects from the vaccine that are unique to children. And I'm reassured by all of those, the answers to all of those questions, that we are on the right track to promote vaccination. And I'll just add to your comment about wastewater detection. That's not a new phenomenon. We've been checking the environment for infectious agents for some time now. It's being used to track polio in other parts of the world by detecting whether polio is in the wastewater. So it's an interesting approach, and very novelly applied to COVID.
Thanks. And I'll let you have the last couple words, Dr. Mandel.
Well, I would just say, I think it's no secret how politically divided the country is in many ways. And I think all of us in healthcare and public health really don't want to see that type of division spill over into this realm. You know, we are truly all in this together. These are our neighbors, our friends, our community that, you know, we all want to take care of and to do well. And let's just keep our eye on that ball and see what we can do.
I think that's a great note to end on. And I would like to thank you both today for participating, and also like to thank our county communications team who did the hard work to set this panel up, and also our two translators, Barbara and Anna. I asked them if it was okay to use their first names, and they said yes. I hope that those who are listening will go to our website, coronavirus-sd.com, to learn more. We will be posting Dr. Schooley's talk about immunity on the website, and we have a lot of resources there if you did not get a question answered today based on this discussion. So again, thank you for participating, and this session is now concluded. Thank you.